So this lecture is going to look at various drugs of abuse. Special thanks to the other Dr. Braderick and Dr. Persons for basically kind of giving me all the information about these very interesting and highly illegal drugs. Just a brief note, in terms of drug scheduling, when we talk about Schedule 1, Schedule 2, this is what we're talking about. Schedule 1 drugs have a high potential for abuse. There's really no currently accepted medical use in the United States, and you can't prescribe it. So these are all of your illegal drugs. MDMA, ecstasy, marijuana would probably be taken off this list. And actually, marijuana, I think, deserves kind of a special topic, and so I didn't put it, I cut it from the drugs of abuse lecture. We'll cover marijuana by itself next year because it's so interesting and very current, and so I'm going to cut it from I cut it from this lecture. These are drugs that are illegal: LSD, heroin, and all these other things that you've heard about. Schedule 2 drugs have a high potential for abuse, and so here's your morphine, your cocaine, PCP, classic opium. Your Schedule 3 drugs have the potential for abuse, but are still used clinically, as is the schedule before. And so we're looking at ketamine and some of these precursor type molecules, anabolic steroids. These have clinical use, but very specialized. Schedule 4 have a relatively low abuse potential. Here's your benzodiazepines. And Schedule 5 have the lowest abuse potential in the US. And these are your opioid preparations of the anti-diarrheal and anti-coughing medications. And so this list was basically initiated around the 1970s when Richard Nixon was in office. And so again, just to kind of recap, the Schedule 1 have really kind of no currently accepted medical use. The Schedule 2 have, clinical use, but there has to be some kind of restrictions and oversight. And then Schedules 3, 4, and 5 are very clinically relevant and used in treatment all the time. Okay. Excuse me. One of the things that I do want you to keep in mind, and we'll kind of talk about this throughout this lecture, is how these drugs are administered. And so the way in which these drugs are administered affects not only how quickly they have their effect, but how quickly they end their effect. And so basically talking about the duration of action. And this chart nicely summarizes all of the different administration techniques that people with substance abuse disorders use. So certain drugs can be inhaled, certain drugs can be injected IV, other drugs are snorted or snuffed through the nose, some of them are ingested as well. And so the time in which they kind of persist and the time in which they have their effect varies, basically depending on how these drugs are used. Excuse me. And then in terms of the drug classifications, when we talk about sedative hypnotics, we're loosely kind of putting in alcohol, barbiturates, benzodiazepines. When we talk about narcotics, we're specifically referring to products derived from opium, so morphine, heroin, codeine. And of course, these two classes were covered in the opioid lecture previously. Dissociative drugs include PCP and ketamine, hallucinogens, LSD, mescaline, ecstasy, and then of course stimulants, some of which we've already covered as well: caffeine, nicotine, cocaine, amphetamine, and methamphetamine. So let's do the CNS depressants first. We're looking at two classes: the sedative hypnotics and the narcotic. So ethanol, or alcohol, is probably the most widely used and abused drug in the US, and of course it is a depressant. Mechanistically, it's an NMDA antagonist, specifically at the glutamate receptors. It'll stimulate the release of the endogenous opioids, and that's important in terms of treating some of these patients. You'll see why later. And it also enhances GABA transmission at the GABA subtype A receptors. And so you can see a lot of tolerance building up to these to alcohol, and you can see a lot of enzyme induction in people that are chronic drinkers. The kinetics of alcohol are pretty interesting. It's very quickly and efficiently absorbed into the bloodstream from the stomach. And of course, carbonated alcoholic beverages like champagne have even a faster absorption process. This drug or drugs get rapidly distributed throughout the body, and of course, you all know they're metabolized or biotransformed by the liver. And of course, we had previously mentioned some of the acute versus the chronic effects in different capacities of some of these cases that we've talked about. At low concentrations, there's a sense of euphoria, and you see the production of disinhibition release. You can see some local vasodilation, and of course, a minor loss of coordination and some slurred speech. But as the concentration of alcohol increases, the sedation part becomes more prevalent. Some patients get nauseous, some do vomit. Mental confusion ensues. Respiratory depression is notoriously seen with kind of high dose alcohol intake, leading to and including coma. Some of the chronic effects in people that are long-term abusers of alcohol include a tingling sensation in the feet, irregular heartbeat or arrhythmias, liver disease, of course, sexual dysfunction, loss of memory, as well as confusion and hallucinations. Now, the terminology for alcohol abuse is pretty interesting. We can classify risky use in terms of consumption of an amount of alcohol that puts an individual at a high risk for a health consequence. We can talk about binge drinking, drinking high amounts of alcohol within a relatively short time frame. For men, that's about 5 drinks, and for women, that's about 4 drinks. And then, of course, as you kind of go through the progression, we're looking into alcohol use disorders, and this is a pattern of alcohol use that's got specific DSM-5 criteria. Now, for the management, we can give several drugs to help curb some of this alcohol abuse. Chlordiazoxide, which is basically benzodiazepine, basically prevents physical symptoms associated with alcohol withdrawal. We can also give naltrexone, yes, the opioid antagonist. That's basically first-line therapy. Blocks the use or blocks the effects of the endogenous opioids. The only caveat is that you can't give it to a patient who's on opioid therapy. And then the other drug that we can use is a camprosate, and I think we had talked about this in a previous case as well. And this is looking at the modulation of glutamatergic transmission and GABA transmission. And here you can see a reduction in alcohol craving, and actually this drug is well tolerated. In terms of other management strategies, we can use disulfiram, which is kind of a second-line therapy. This drug inhibits aldehyde dehydrogenase, basically leading to an accumulation of aldehyde products. The effects of this drug include skin flushing. You can see some tachycardia and hyperventilation, but it induces a conditioned avoidance response. So if the patient does drink while they're on disulfiram, they're going to feel horrible. And so it's going to basically help kind of re-educate the brain into not craving alcohol, but having a disdain for it. So it's a really kind of a useful drug, but it is kind of second-line therapy. So I think we'll end there, and we'll go into the benzos in the next lecture series.